At ESMO 2023, I had the pleasure to provide an update of KEYNOTE-522. Just to remind you of the design of KEYNOTE-522, it was the first Phase III trial to investigate the addition of the immune checkpoint inhibitor Pembrolizumab to neoadjuvant chemotherapy in patients with stage 2 or stage 3 triple-negative breast cancer. Patients were randomized 2-to-1 to receiving Pembrolizumab or placebo in combination with chemotherapy for 6 months. Then they had surgery and then carried on with Pembrolizumab or placebo for another 6 months. The chemotherapy regimen was intensive, 12 weeks of carboplatin paclitaxel followed by 12 weeks of AC or EC. The trial has 2 primary endpoints, short-term endpoint with pathCR, and we have previously demonstrated that the addition of Pembrolizumab significantly increased pathCR rates by about 13.6% from 51 to nearly 65%. We had also previously demonstrated in the second primary endpoint, event-free survival, which is the long-term benefit, that we had demonstrated after 39 months of follow-up that the addition of Pembrolizumab significantly reduced the risk of recurrences by about 37%. Now at ESMO 2023, we presented 5-year follow-up data, to be precise, 63 months median follow-up now. That's really important for triple-negative breast cancer. If you look at early triple-negative breast cancer, the recurrence pattern is very different to other subtypes. We see most of the recurrences happening in the first 5 years. In fact, about 70% of the recurrences usually happen in the first 3 years, 85 to 90% of the events in the first 5 years. So if you have an neoadjuvant adjuvant study with 5-year follow-up, you have robust, you have definitive data. What we've demonstrated here is that the result has remained absolutely stable. The hazard ratio for event-free survival is 0.63, significant and meaningful benefit. If you look at the 5-year event-free survival rates, there were 81% with Pembrolizumab and chemotherapy compared to 72% with chemotherapy and placebo, significant benefit. If you look at the benefit across subgroups, age, PD-L1 status, nodal status, stage, for example, it's consistent. There's not a single group we would take out and say they don't benefit from Pembrolizumab in this setting. We were unable to present overall survival data. It's an event-free analysis, and we haven't seen the events, which I suppose is a really positive sign, as patients I assume, in the Pembrolizumab arm are doing much better, and therefore we haven't seen patients' death. On the other hand, we have seen that in distant metastatic event-free survival, again, we see a significant and meaningful benefit with a hazard ratio of 0.64 and a delta, a difference in 5-year distant metastatic event-free survival rates of around 8%. A really interesting additional analysis pre-planned was looking at the outcome at event-free survival of patients with a pathCR or with residual disease. It's well established that if someone experiences a pathCR with preoperative therapy, they have a fantastic outlook. However, what we've seen now is that if you achieve a pathCR with chemotherapy and Pembrolizumab, the outlook is better than if the pathCR is achieved with chemotherapy alone. The 5-year event-free survival rates with pathCR with chemo and Pembrolizumab is 92% compared to 88% with chemotherapy alone. And this suggests to me that the quality of the pathCR can be very different in terms of how you achieve that pathCR. The second learning is in patients who have residual disease, and unfortunately patients with residual disease still have a relatively high risk of disease recurrence, but we have more than 10% better 5-year event-free survival rate if patients achieve or had residual disease after chemotherapy and Pembrolizumab compared to chemotherapy alone. So in summary, KEYNOTE-522 has now really robust 5-year mature data confirming there's a substantial benefit not just in pathCR rates, but more importantly in event-free survival rates, reducing the risk of recurrence by 37%, but also demonstrating that patients who have a complete pathological response seem to be doing better if they had immune therapy than if they had chemotherapy alone with a 4% delta.